So for about 5% of the population of European descent, there's this highly specific genetic mutation. And it basically turns a standard menopause treatment from like an absolute lifesaver into a hidden landmine.
Yeah, it really does. It's a massive shift in risk.
Welcome to today's deep dive. We are looking at Factor V Leiden today. And we're going to explore why the exact same hormone therapy can either give you your life back or multiply your risk of a deadly blood clot by 25.
Right, and it all depends entirely on how that hormone actually enters your body, which is just fascinating.
It is crazy. So we're pulling from a pretty robust stack of sources for this. We've got the latest clinical guidelines from the British Menopause Society and NICE.
We also have some really deep genetic data from gender reviews, plus rigorous large-scale research, right? Like the Women's Health Initiative and the Esther study.
Exactly. And our mission today is to answer one very specific clinical question. Can menopause trigger an increased risk of deep vein thrombosis in women who carry the Factor V Leiden mutation?
And, the short answer is that the interaction between shifting hormones, vascular aging, and this specific genetic variant creates a highly volatile environment.
But the longer answer is a lot more complex, right?
Oh, absolutely. Because it isn't just about estrogen levels dropping or rising. I mean, it's fundamentally about hepatic function, vascular biology, and how different delivery systems interact with your genetics.
Okay, let's unpack this, because before we even introduce that genetic wildcard, we really need to establish the baseline of what is physically happening to a woman's cardiovascular system during a standard menopausal transition.
Right, because the risk of a venous thromboembolism, or a VTE, naturally rises as women age anyway.
Yeah, does menopause directly cause blood clots, or is it just a byproduct of getting older? Because we're looking at an absolute risk of about 0.5 per 1,000 women before age 50.
But then you jump to over age 60 for women who are not on any hormone therapy at all, and that risk naturally rises to 2 or 3 per 1,000.
So it does go up significantly.
It does. And that shifting baseline is basically driven by two concurrent physiological changes. You have the loss of endogenous estrogen and then just natural vascular aging.
An endogenous just means the estrogen your body makes naturally, right?
Exactly. Throughout your reproductive years, that estrogen plays a highly protective role in your vascular health. It binds to receptors on the endothelial cells.
Which is the inner lining of the blood vessels.
Right, the inner lining. And it promotes the constant release of nitric oxide. Now, nitric oxide is a potent vasodilator.
So it keeps things wide open.
Yeah, it keeps the blood vessels pliable, relaxed, and open, which allows the blood to flow smoothly without any turbulence or, pooling.
Okay, so when women hit the menopausal transition, which is usually around a median age of 51, those estrogen levels fluctuate and ultimately plummet. So that nitric oxide production just stalls out.
It does. The endothelial cells lose that constant chemical signal to stay relaxed, and the vessels literally lose their elasticity. They get stiffer.
Wow. So when blood vessels stiffen and that inside space narrows down, the flow of blood just slows down.
Hemodynamics tells us that anytime blood flow becomes sluggish or pools, particularly in the lower extremities, your risk of a clot forming increases. But that's really only half of the baseline equation.
Oh, right, because the other half is happening in the liver.
Exactly.
Because the liver is synthesizing the proteins responsible for the coagulation cascade, right?
Yeah.
Like fibrinogen, prothrombin, all those clotting factors.
It is. The body maintains this very delicate hemostatic balance. I mean, you need the ability to form a clot instantly if you cut yourself to stop tissue damage.
Right, obviously you don't want to bleed out.
But you also need natural anticoagulants circulating to prevent clots from forming spontaneously inside healthy vessels. And estrogen actually influences the liver's production of those proteins.
So when estrogen levels get erratic during perimenopause and then eventually settle at those really low levels postmenopause, it disrupts that whole process.
Yeah, it disrupts the hepatic synthesis of those coagulation factors. So the baseline essentially tips slightly toward a prothrombotic state.
Meaning you're just naturally more likely to clot. So we're looking at a 4 to 6 times increase in the risk of a clot just from like the passage of a decade and that natural loss of vasodilation.
Right. And that is just the baseline for a woman with standard genetics.
But what happens if we overlay a genetic glitch that already has her blood primed to clot? Let's bring in Factor V Leiden.
This is where it gets complicated.
Because if normal blood clotting is like a car that applies the brakes when you cut yourself, is Factor V Leiden like having a sticky brake pedal that won't release? So it just causes the blood to clot way too much.
That is a really, really accurate way to conceptualize the pathology. To use the medical terminology, factor V Leiden causes activated protein C resistance.
Okay, activated protein C resistance. What does that mean exactly?
Well, in a normally functioning cascade, once a clot has done its job, this enzyme called activated protein C, or APC, comes in to stop the process. It's the braking system.
So it tells the body, okay, we're done here. Stop clotting.
Right. APC specifically targets and cleaves factor V, which immediately halts the production of thrombin and stops the clot from growing.
But the mutation in factor V Leiden physically changes the structure of that factor V protein, doesn't it?
It does. It's actually a single-point mutation. There's a specific amino acid substitution that alters the physical shape of the cleavage site on the protein.
So it changes the shape, meaning the brake pedal is physically broken.
Exactly. Because of that structural change, the activated protein C enzyme literally cannot bind to the site. The chemical off switch is physically blocked.
Wow, so APC resistance means the coagulation cascade just continues unchecked, all because the enzyme meant to shut it down has nowhere to attach.
You've got it. And Jenner reviews provide some really stark data on the prevalence and the risk multiplication here. It matters immensely whether a patient is heterozygous or homozygous for this mutation.
Right, heterozygous means you got it from one parent. Homozygous means you got it from both. Let's talk about heterozygous first.
So heterozygous is incredibly common. It affects roughly 5% of people of European ancestry. And if you have that, your risk of a VTE is 3 to 8 times higher than someone without the mutation.
Wait, 5%. That means millions of women are entering menopause with this heterozygous mutation, constantly running at a 3 to 8 times higher baseline risk of a blood clot.
Millions.
Yeah.
And if a patient is homozygous, inheriting it from both parents, it's a far more severe environment.
How much more severe?
Well, it's rarer, appearing in about 1 in 5,000 people. But for them, the risk of a VTE massively increases by 18 to 80 times compared to the general population.
18 to 80 times.
Hmm.
And the clinical guidelines point out that these VTE risks are not additive, right? They're multiplicative.
That's a crucial point. You don't just take the baseline age-related risk of 3 per 1,000 and add the genetic risk. You multiply them together.
Which is why the transition through menopause for these women requires such precise management.
Absolutely, because if you take an aging vascular system losing its flexibility and multiply that by a mutation blocking your anticoagulant enzymes, you are looking at a highly primed prothrombotic state.
Here's where it gets really interesting, though, because you're losing me on a core piece of the clinical logic here.
Okay, what part?
Well, we just established that a lack of estrogen in menopause stalls nitric oxide, stiffens vessels, and tips the liver into a clotting state. So if hormone replacement therapy puts the estrogen back into the system, shouldn't that fix the problem?
You would think so, right?
Yeah. Why does the cure suddenly trigger a massive risk increase for blood clots? Wait, if dropping estrogen causes vascular issues, why does adding it back increase the risk?
It is the central paradox of hormone therapy. And the answer comes down entirely to the route of delivery. It's not the estrogen itself that triggers the massive VTE risk.
Okay, so what is it?
It is first-pass metabolism. When a patient takes oral estrogen, swallows a pill, the medication is absorbed through the GI tract.
Right, the stomach and intestines.
And then it is transported straight to the liver via the portal vein before it ever reaches the systemic circulation.
Oh, wow. So the liver takes the absolute full concentrated hit of the dosage before the rest of the body sees a single molecule of it.
Exactly. This first-pass metabolism forces the liver to process an unnaturally high concentration of estrogen all at once. And remember what we said about the liver.
That's the exact site where coagulation proteins are synthesized.
Yes. So when you flood the hepatocytes with oral estrogen, it aggressively stimulates the synthesis of prothrombin, and it decreases the production of natural anticoagulants.
So it's basically throwing gasoline on a fire.
It really is. It also spikes the levels of D-dimers in the blood. D-dimers are protein fragments produced when a blood clot dissolves, so they act as a primary biomarker that the coagulation system has been highly activated.
So swallowing the pill basically sounds a massive alarm in the liver, forcing it to churn out clotting factors.
Right. And for a woman with standard genetics, this first-pass metabolism increases her VTE risk by about 2 to 4 times.
Which is an increase, but usually clinically acceptable given how low her baseline risk is to begin with.
But if we introduce the factor V Leiden mutation to that exact same oral delivery,
It becomes a catastrophic pharmacological collision.
it does, because you are taking a vascular system that already cannot physically turn off the clotting process because of that APC resistance, and you're flooding it with a fresh surge of clotting factors.
And the ester study data really exposes the magnitude of this collision, right?
Oh, the ESTER study is brilliant. It was a major French case control study specifically designed to evaluate the risk of VTE in postmenopausal women using different routes of estrogen therapy.
And they meticulously genotyped the participants for prothrombotic mutations, including factor V Leiden.
Yeah, the methodology is what makes it so irrefutable. They didn't just look at broad population trends, they isolated the delivery mechanisms.
They matched cases of documented VTEs with perfectly matched controls, right?
Exactly, which allowed them to isolate the specific interaction between the oral route, the genetic mutation, and the clotting event itself.
And the numbers they found are staggering. They looked at non-users without any genetic mutations as the baseline.
Right.
And compared to them, women taking oral estrogen who also carried a prothrombotic mutation like factor V Leiden saw their VTE risk skyrocket to an odds ratio of 25.5.
A 25.5-fold increase in the risk of a life-threatening blood clot, directly resulting from the collision of first-pass metabolism and activated protein C resistance.
That's 25 times the risk. And we had to factor in other variables that push that multiplier even higher, don't we?
Oh, absolutely. Data from the MEGA case control study looked at the compounding effects of a high body mass index.
Right, so if a woman with factor V Leiden takes oral estrogen and also has a BMI over 30,
the mechanical pressure on the veins combined with the systemic inflammation of adipose tissue can push that risk multiplier to 35 to 50 times the baseline.
35 to 50 times. I mean, the liver simply cannot handle the load of oral estrogen without tipping a mutated clotting system completely into the red zone.
The production of thrombin just vastly outpaces the body's broken ability to shut it down.
So what does this all mean for you? If you have factor V Leiden and terrible menopause symptoms, are hormones completely off the table?
It definitely sounds like a definitive end to the conversation, doesn't it?
Yeah, it implies you just have to suffer through the hot flushes, the joint pain, the bone density loss, all because the medical treatment is too dangerous.
But that is the most crucial misconception we really have to dismantle today. You do not have to abandon estrogen therapy.
Wait, really? You don't?
No, nor do you have to suffer. You just have to bypass the liver.
Ah, the transdermal delivery route.
Yes, what's fascinating here is the transdermal loophole. When estrogen is administered through the skin via a patch, a gel, or a spray, it's absorbed directly into the capillary blood vessels just under the dermis.
And from those capillaries, it enters the systemic bloodstream immediately.
Exactly. It completely circumvents the gastrointestinal tract and the portal vein, which means it completely avoids first-pass hepatic metabolism.
So the liver never gets flooded with that concentrated bolus of estrogen.
Never. And because the liver isn't subjected to that spike, it never receives the signal to alter its synthesis of coagulation proteins.
So fibrinogen levels don't spike, prothrombin remains stable, and those D-dimer biomarkers do not elevate.
It is a brilliant physiological workaround. You achieve the systemic levels of estrogen required to stop the hot flushes, protect the bone density, and restore the nitric oxide production.
All without alerting the liver's coagulation factory.
Precisely. And the data validating this is incredibly strong. If we return to the ESTER study, they specifically tracked the women with prothrombotic mutations who are using transdermal estrogen instead of oral.
And what did they find?
The transdermal route did not induce any further activated protein C resistance. It just did not activate the blood coagulation cascade the way oral estrogen does.
The specific odds ratio for those women is honestly the most vital piece of data in this entire deep dive.
It really is. Let's look at the numbers.
For women with a factor V Leiden mutation who were taking transdermal estrogen, their risk of a blood clot was an odds ratio of 4.4.
And we have to contextualize that 4.4. Remember what the baseline risk is for simply walking around with a heterozygous factor V Leiden mutation.
It's 3 to 8 times higher than the general population anyway.
Exactly. The 4.4 odds ratio sits perfectly within the baseline risk of the genetic mutation itself. The patch added zero additional risk.
Zero additional risk. I mean, the patch provides the exact same symptom relief as the pill, but because it sneaks the estrogen past the liver, the 25-fold risk multiplier completely vanishes.
This physiological reality is exactly why the clinical guidelines are so explicit now.
Right, the British Menopause Society and NACs.
Yeah, they have heavily updated their frameworks to reflect this data. They state unequivocally that oral hormone replacement therapy is contraindicated for patients at high risk of a VTE.
Including those with known prothrombotic mutations. You just do not prescribe the pill to someone with factor V Leiden.
But those same guidelines explicitly support transdermal HRT. They clarify that transdermal estrogen at standard doses represents no greater risk than the baseline population risk.
So they've essentially decoupled the hormone from the clot risk just by changing the delivery mechanism.
It represents a massive shift in how we approach risk stratification in medicine. Historically, a prior clot or a known genetic mutation was an absolute contraindication for any kind of hormone therapy.
Right. Women were just universally denied treatment.
But now, the guidelines require clinicians to stratify the risk based on the pharmacological route. It's a huge step forward.
So what this ultimately means for you, especially if you have a family history of unprovoked blood clots, is that the clinical approach requires nuance.
It does. And the guidelines actually stress that a documented personal or family history of blood clots is often a more useful clinical indicator than ordering broad genetic testing for everyone.
Because routine genetic screening for asymptomatic individuals isn't widely recommended, right?
Right. Finding a heterozygous mutation in someone with no personal or family history of clots often doesn't change the primary clinical outcome, provided they are managed correctly.
But if that family history is present, or if you already know your factor V Leiden status from previous testing, it fundamentally dictates the specific parameters of your menopause care.
Absolutely. You have to advocate for yourself and ensure your provider understands the distinction between hepatic and systemic absorption.
So to bring all of this physiology together, menopause itself causes a decline in estrogen, which stalls nitric oxide production and stiffens the vascular endothelium.
Right. That's the baseline aging process.
And when you combine that natural aging process with a factor V Leiden mutation, where a structural defect physically blocks the body's natural anticoagulants,
The hemostatic balance is already teetering.
the actual trigger that pushes that system into a life-threatening deep vein thrombosis is first-pass hepatic metabolism. Swallowing an oral pill forces the liver to mass-produce clotting factors that a mutated system physically cannot shut down.
But by utilizing transdermal delivery, like a patch or a gel, we achieve the necessary systemic estrogen levels while keeping the liver entirely out of the equation.
It neutralizes the pharmacological risk entirely, just returning the patient to their baseline genetic risk.
It really is an elegant solution to what used to be an insurmountable medical problem.
It is. And this precise biological interaction brings me to a final thought for you to mull over. It's directly inspired by the data tucked inside the Women's Health Initiative trials.
Ah, yes. The WHI was massive.
It was. And one of the most fascinating aspects of their thrombosis research involved those biomarkers we talked about earlier. They found that a simple blood test for D-dimers could actually evaluate a woman's underlying hidden risk for thrombosis before she ever started hormone therapy.
Right, because an elevated D-dimer level indicates that the coagulation cascade is already secretly hyperactive.
Even if a clot hasn't fully formed or caused symptoms yet.
It's basically a real-time chemical snapshot of the hemostatic balance in the body.
Exactly. And the researchers noted that women who had high D-dimer levels at baseline, before taking any hormones, were the ones who suffered the most dramatic risk increases when given oral HRT.
So the predictive power of that test is undeniable.
So here is the concept to explore on your own. We now know that the route of delivery can mean the difference between a 25-fold risk increase and zero added risk.
Yeah.
And we know that genetics and circulating biomarkers can perfectly predict how a patient's liver will react to oral estrogen.
Right.
So if the math is this clear and the biomarkers are this predictive, why is the standard of care still so heavily reliant on family history questionnaires?
It's a great question.
Could routine biomarker screening, like checking every single woman's D-dimer levels and coagulation status before prescribing menopause treatment, be the key to completely eliminating iatrogenic blood clots?
I mean, if we have the ability to see exactly how the blood is behaving before we introduce a catalyst.
Exactly. Perhaps proactive hematological screening should become as standard to menopause care as checking blood pressure. Could routine screening be the future of personalized, risk-free aging?
It certainly makes you wonder.
It really does. All right, that wraps up our look at Factor V Leiden. Thanks for joining us on this deep dive.